Hi, I'm Anthony Gosh, lead consultant spinal neurosurgeon at the Spine MDT, and this is the part 2 video on deformity. We're focusing on kyphosis of the spine. There's a link below to the previous video, the part 1 video, which is more focused on scoliosis, which is a side-to-side curvature of the spine. Let's quickly look at the spine. So you can divide it up into the cervical spine, which is the neck area, the thoracic spine, which is kind of braced and housed within the rib cage, the lumbar spine, which is your lower back, and then you've got the sacral spine, which is a fused segment of the spine within your pelvis, and then below that the coccyx area, which is the tailbone. Now naturally there is a backward curvature here in the neck, and that's a natural lordosis, we call that. So a normal alignment of the spine has a lordosis. In the thoracic area, there is already a normal lordosis, that forward curvature that pre-exists. It is perfectly normal. In the lumbar spine, there's a backward curvature, again called a lordosis. So kyphosis as a deformity is when you have an excess of this forward flexion, either in the thoracic spine, but it can also occur in the cervical spine, where this starts to angle forwards, and in the lumbar spine, again, where that angles forwards excessively so. And we'll talk about the different causes of this. We can see this in young adults. We commonly see kyphotic deformity in a more aging population, and generally speaking, what we say is more than the normal amount is a Cobb angle of between 20 and 40 degrees or so. So if you were to draw a line from the peak of the curvature at one end of the curve and the other end of the curve, and measure the angle, anything greater than 20 to 40 degrees, between 20 and 40 degrees or more, it is a kyphosis. And then the reason it's common in elderly patients is a multitude of factors that's been explored and not fully explained. So one theory is that as we get older, you can get crumbling of the bones, the individual bones themselves, the vertebral bodies. And the reason that theory's come about is we see more of this in females than in males, and things like osteoporosis and osteopenia, so brittle bones, is more common, especially after menopause. When estrogen levels drop, the bony density and integrity drops, and you can get microfractures and collapses in bones. And whilst we do see that, and that is a very well recognized cause, actually in a good chunk of patients in various studies done show that in a lot of patients with a kyphosis elderly, no identifiable fracture or collapse is seen. But microfractures from osteoporosis over time, when each of these bodies starts to form a slight wedge shape, and as you pile them on top of each other, it starts to form this forward angulation. Another problem that happens as we age is degenerative change. That's wear and tear, and that's in the discs, the cushion between the bones. It starts to collapse, and if it collapses more at the front than at the back, and then again over a whole stack of these bones, over a whole segment, that will cause it to gradually crumble down. And then there's the theory of ligamentous laxity. The little ligaments are straps of tissues that kind of hold bones together. They lose some of their, over time as they stretch, they lose their elasticity, and then they just remain stretched, I suppose, and then allow that curvature to occur. And in sedentary lifestyles, lack of mobility, over time, the paraspinal muscles, the band of muscle that runs down the back of the spine that essentially pulls you upright, weakens over time, and then the curvature starts to form. And often it's actually a combination of all of these factors. There are also genetic aspects to this. You do see this inherited to some degree. So there are some genetic elements as to why that can happen. And then beyond that, we then get into actually more progressive or more severe pathologies as a cause of this. So what I've described happens over time. It's a gradual process, but I've previously done a video on osteoporotic fractures that can be acute and then it can progress quite quickly. So here, if we have a bone that's crumbled down completely, it can happen quite acute and quite quickly, where you get the forward curvature. And I've previously done a video on this. There's a link to this below, and procedures we can do to prevent that collapse further. So kyphoplasty in this case, where for a little nick in the skin, you can pass a needle under image guidance into the bone, inflate a balloon, and inject some cement into the bone to harden it up, but also to restore its height and help correct the angulation. And therefore, it's important to now move on to slightly younger patients who can suffer fractures from direct trauma, where a bad fracture of a bone doesn't heal properly, and over time there's a forward curvature. And then there are pathological fractures in younger people or elderly people where tumours or cancer spread to the bone, cause them to collapse, and they're normally associated with a lot of pain as the deformity develops. If the spinal cord is at threat, the neural structure that runs up and down the spine that transmits messages to and from or between the brain and the body, if that's at threat, that's often when we carry out surgery to protect it and stabilize the segment of the spine. That is very rare in the osteoporotic fractures and extremely rare in degenerative elderly kyphosis itself. In younger children and adolescents, we have a condition known as Sherman's disease. Like with scoliosis, what I said in the previous video, the growth plates here, the end plates of the vertebral bodies, are where the growth cells are, where the growth starts from. And if there's an imbalance in where those cells are distributed, i.e. if they are towards the back rather than the front, the back of the vertebral body grows quicker than the front. And as these children grow, especially at that pubertal growth spurt, it can start to progress. There are some genetic studies and there is some inheritance seen in this, and it's often diagnosed quite late. But in terms of treatment, if it can be caught at the start of the growth spurt, if it's noticeable, then special braces you can wear, a kind of corset that helps restrict growth at the back and a bit looser at the front, can help shunt that and improve things, in combination with physiotherapy to try and build more tone in the muscles, the paraspinals at the back of the spine, to help hold an upright posture. It is extremely rare in this condition that surgical correction is required when you compare this condition to scoliosis, the side-to-side curvature. So for age-related hyperkyphosis and Sherman's disease in adolescents, the treatment is usually physiotherapy with or without the use of special corsets to just help improve the posture just for functional purposes. It is extremely rare surgery is required. In the context of acute pathology, such as an actual acute fracture of the spine, be it trauma or secondary to osteoporosis, these are the only indications where sometimes, not always, sometimes surgery is required to either protect the spinal cord or for stability, rather than just correction of the deformity itself. So that's it for the deformity series. We did scoliosis and kyphosis. Theoretically, there's lordosis or hyperlordosis, which is the backward curvature, which you can see in the lumbar spine, secondary to excess muscle tone at the back from specific exercises people have exerted themselves in or overused. Some injuries can cause it, some wear and tear. These are very, very rare indeed, and not very common, never usually require any surgery or anything like that, which is why I haven't done a whole separate video on it. If you found the video helpful, please feel free to visit spinemdt.com on the link below. You can try our free online spine assessment questionnaire. Our mission at the Spine MDT is to try and find the least invasive solution that gives you the longest lasting result, and we're able to do that by bringing together all the different professions of spine care. So osteopaths, chiropractors, physiotherapists, pain specialists, and offer care all under the supervision of a spine surgeon, the oversight of a spine surgeon. If If you did find this video helpful, please click the like button and subscribe. It really helps people troubled with back pain and spine disease find information that I try and post on this channel every week. Thank you.